Did you know there is more than one type of hip replacement, each with its own advantages and disadvantages? Many people don't know this and just assume that a hip replacement is the same across the board, but that's not true. There are several different types of total hip replacements, and they all differ in many ways, from where the incision is located, how long it takes to heal, to complications after surgery including chronic muscle weakness, dislocation risk, and even fractures. But which total hip replacement is the best choice? Well, in this video, we have put together a comprehensive guide to total hip replacement types, covering all the pros and cons of each type of approach. And stick around until the end, where I will be covering what I believe to be the best overall hip replacement approach. The choice of surgical approach for total hip replacement depends on many factors, including the person's anatomy, the type of hip condition being treated, and the person's overall health, but it is also often based on surgeons' training and expertise. Surgeons will primarily utilize the approach that they learned during their surgical residencies and feel most confident in. But regardless of the approach, the primary objective of all total hip replacements remains the same: alleviating pain and improving the quality of life in the presence of hip issues, such as advanced arthritis. Now, there are several approaches out there, but today we will cover the four main types of hip replacements performed, including the posterior, direct lateral, anterior lateral, and direct anterior approaches. The posterior approach is the most common method of hip replacement surgeries, making up roughly 55% of total hip replacements performed. During this approach, the surgeon creates a curved incision at the back of the hip, splitting the fascia lata, iliotibial band, and gluteus maximus muscles. Next, the short external rotators, including the piriformis, gemelli, and obturator muscles, are attached from the femur bone at their tendons to access the hip joint. The posterior capsule is then split to reach the hip joint for the replacement procedure. After the hip replacement is completed, the tendons are then repaired. There are many advantages to the posterior approach, with one of the biggest advantages being it spares the hip abductor muscles, which include the glute medius and minimus. These muscles have a very important functional role as they provide stability of the pelvis and prevent it from dropping when walking. As you will see in a little bit, other approaches impact the strength of these muscle groups, which can result in a permanent limp after surgery, known as a Trendelenburg gait. So the fact that this approach spares these muscles is a big plus. The posterior approach also provides the surgeon with excellent visibility of the hip joint. With a clear view of the hip joint, the surgeon can make sure the components are aligned correctly, minimizing the risk of complications and ensuring the best possible outcomes for the patient. With some of these less invasive procedures, the surgeon does not have as good visualization, which can make it harder to ensure proper alignment of the surgical components. Another benefit of the posterior approach is that it can easily be converted to more extensile exposures if needed. Extensile exposures typically involve techniques that extend the surgical approach beyond its normal boundaries to access areas that may be difficult to reach or visualize with other approaches. This may be necessary in cases where there is extensive bone loss, deformity, or other unforeseen complexities encountered during surgery that require more thorough visualization and manipulation during the surgery, helping to improve surgical outcomes. But despite its popularity, there are some drawbacks to the posterior approach. Since the approach requires the splitting of several muscles and detachment of the short external rotators, there is unavoidable muscle damage associated with this approach, which can lead to increased pain, longer recovery times, and residual muscle weakness of the hip rotators. And although small, there is also a slightly higher risk of dislocation with the posterior approach due to disruption of the short hip external rotators and posterior joint hip capsule, which reduces the stability of the joint. This is why those who receive a posterior hip replacement are asked to follow specific precautions and movement restrictions during the recovery period. This typically requires patients to avoid positions of excessive hip flexion, internal rotation, and adduction, where the leg is brought across the body for the first 6 to 8 weeks. And next to the short hip external rotators is the sciatic nerve, which is the nerve at risk during this approach. This nerve runs next to the short hip external rotators and controls the muscles and sensation in the leg, and can be injured if not protected during surgery. This is typically due to the sciatic nerve being compressed under the surgical retractors, which are tools used to hold back soft tissues and provide exposure to the hip joint during hip replacement surgery. The direct lateral approach, also known as the transgluteal approach, is the second most common method of total hip replacement, accounting for about 20% of all total hip replacements performed. During this approach, the incision is made along the side of the hip, splitting through the fascia lata and gluteus maximus muscles. Once the incision is made, the surgeon retracts the gluteus maximus muscle to access the deeper layers. Within the deeper layers, the gluteus medius muscle is detached from the bone and reflected along with the gluteus minimus to expose the hip joint capsule. The direct lateral approach, like the posterior approach, offers surgeons excellent visibility of the hip joint, allowing for precise implant placement for optimal alignment and function. Also, it tends to have a lower dislocation rate compared to the posterior approach. However, one notable concern with this approach is the resultant muscle damage. Studies have found that between 4 to 20% of patients undergoing the direct lateral approach experience varying degrees of hip weakness post-surgery. Interestingly, this weakness isn't solely attributed to the procedure itself. It's also linked to pre-existing hip muscle degeneration, which affects up to 25% of total hip replacement recipients. So considering the muscle quality before surgery becomes crucial, as degenerative muscles may not recover as effectively following direct lateral approach. Research also indicates that bone loss often occurs around the implant site in the hip following total hip replacement surgeries, increasing the risk of fractures. Using bone mineral density digital X-ray techniques, researchers found that patients who underwent direct lateral approaches experienced more significant bone loss in the hip region compared to all other types of hip replacements. And instead of the sciatic nerve being the primary nerve at risk during this operation, like in the posterior approach, the superior gluteal nerve is the one that surgeons must keep an eye on. This nerve is a motor nerve which supplies the gluteal and tensor fascia lata muscles. Injury to this nerve can result in weakness of the glutes, which is not great considering these muscles are already likely weak from the surgery, which can compound the issue. There is also an anterior lateral approach, which occurs in roughly 4% of all total hip replacements, and is considered minimally invasive compared to the posterior and direct lateral approaches. The reason for this is the precise location of the surgical incision, with the anterior lateral approach located at the intersection of the gluteus medius and tensor fascia lata muscle groups. This is unlike the direct lateral approach, where the gluteus medius muscle is split. By avoiding splitting the gluteus medius, the anterior lateral approach minimizes disruption to the muscle group, allowing for less soft tissue injury and blood loss during surgery. The anterior lateral approach has been shown to have significantly reduced dislocation rates compared to both the posterior and direct lateral approaches. So this procedure may be beneficial for patients who are at higher risk for dislocation. However, just like the direct lateral approach, the hip abductor muscles still need to be retracted to visualize the joint, which can lead to chronic muscle weakness and a post-operative limp. And despite less tissue injury, the anterior lateral approach has not been shown to improve post-surgical walking quality when compared to the traditional direct lateral approach. The most common nerve-related injury to look out for with this approach is compression neuropraxia of the femoral nerve, caused by surgical retractor positioning. Now, if you're getting value from this video, make sure to take a second and give it a like. We put a lot of time and effort into researching and developing this guide to help you through your rehab journey. Your support will help this video spread to inform more people like you who have rehab-related questions. Also, make sure to subscribe to the channel so you can stay up to date on all of your rehab-related needs. Now, let's get back to the video. The direct anterior approach is the least commonly performed total hip replacement approach mentioned in this video, but is gaining much attention as surgeons seek minimally invasive techniques and more rapid recoveries. The incision for the direct anterior approach is only 3 or 4 inches, compared to up to 12 inches with the more traditional approaches. It is performed through the front of the hip along the bikini line, with the incision located in the intermuscular interval between the tensor fascia lata and glute medius muscles on the outside, and the sartorius muscle and rectus fascia on the inside. So the direct anterior method is considered a muscle-sparing procedure because it does not involve cutting into muscles and tendons to reach the damaged joint. Instead, the surgeon gently pushes the groups of muscles and ligaments aside, inserts the implant, and then moves them back to their proper position. So the major benefit of this procedure is that there is no splitting or cutting of muscles, minimizing soft tissue injury, which helps reduce postoperative pain and eliminates the issue of postoperative weakness that occurs in the other approaches mentioned. This approach also has a very low dislocation risk, as there is no injury to the surrounding muscles, which helps preserve the joint stability. The increasing popularity of this approach has been attributed mainly to reports of reduced operative blood loss, lower postoperative pain levels, and more rapid recovery times. However, the direct anterior approach also has some potential disadvantages. Compared to the other approaches covered, the direct anterior approach has a much steeper learning curve for surgeons. Research suggests that around 50 to 100 surgeries are needed for surgeons to reach proficiency, so it can take some time for them to gain enough skill in this procedure. This approach also poses a risk of injury to the lateral femoral cutaneous nerve, which has been reported in 8% of patients after this approach. However, unlike the other nerves mentioned, the lateral femoral cutaneous nerve is a purely sensory nerve. An injury only causes a patch of numbness on the side of the thigh if this occurs and won't significantly impact function. Wound healing may also pose issues for some, particularly those who are obese with a body mass index over 39. And while fracture is a possibility with all of the approaches, there is some evidence suggesting that direct anterior approach has a slightly higher risk of intraoperative hip and ankle fractures, which has been associated with leg positioning during the procedure due to the use of a specialized traction table. So which approach is the best choice? Well, let's first go through which approaches I would avoid and why. I would avoid the direct lateral and anterior lateral approaches simply due to the disruption of the hip abductor muscle groups. The likelihood of persistent muscle weakness after this approach is simply too great. I wouldn't want to be walking around with a limp the rest of my life, which can place strain through other parts of your body. So I think it boils down to prioritizing outcomes: effective pain relief, improved functional mobility, and long-term durability of hip replacement. Also, minimizing intraoperative and post-operative complications is key. Considering these factors, I lean towards the direct anterior approach. Its significantly lower rates of dislocations and minimal invasiveness make it stand out. But the ability to minimize muscle injury is what gives it the edge on the other approaches, which helps lead to less postoperative pain, a more rapid recovery, and does not compromise the integrity of the muscles, which can impact functional mobility. However, in saying that, it's important to understand that the direct anterior approach is not common, and only a small percentage of surgeons are trained in it, which is limited. So if the direct anterior approach was not available, I would go with the classic posterior approach. While this approach does have a higher risk of dislocation, it's a tried and true procedure that affords the surgeon excellent visualization of the replacement to ensure fit. It's very versatile, allowing for modifications as needed, and it spares the hip abductor muscle groups, which is important for muscle function and ensuring quality mobility. But it's important to remember that a choice of approach should be a collaborative decision between you and your surgeon, based on your unique circumstances. Take the time to thoroughly discuss the options with your surgeon to determine the best approach for your situation. While all total hip replacement approaches have shown positive outcomes, it's critical to choose an approach that your surgeon is skilled in. Research indicates that the best results are achieved when a surgeon has experience and expertise in a particular approach. Really not surprising. Selecting the right surgeon for your operation is the most important thing you can do, and the choice of approach should align with the skill of your surgeon and your individual needs, so do your research. If you found this video helpful, be sure to like, subscribe, and share to help others with similar questions. And stay tuned for the next episode of Physio Show so you can learn more about your body, how it works, and what it needs to keep moving.